This is part 1 of Alterations in Nutrition, the GI system. This is the normal contents in the GI system, as you see here. And there's a figure on page 872 that lists the contents of the GI system. You also should look at the labs for liver function, that's on page 888, and for the pancreas, that's on page 890, and metabolism of bilirubin, which is on page 885. Those are all three important areas for you to look into. Signs and symptoms of GI dysfunction. You have anorexia, which is the lack of desire to eat even though the appropriate stimulation is in place. In other words, you've got good-looking food in front of you, but you just don't have any inclination to eat. Vomiting is also called emesis. This is usually preceded by nausea just before the vomiting. I always use the abbreviation N/V for nausea and vomiting, and so it just kind of came out there. But vomiting is the forceful emptying of the stomach and the intestine of chyme. Projectile vomiting is not preceded by nausea or retching. It just kind of happens. Patient doesn't realize it's going to, and it does. Oftentimes that occurs as a side effect of a drug, but not always. Abdominal pain. There are different types of abdominal pain. Parietal means that it's somatic, it is localized. Visceral, it has to do with an abdominal organ, it radiates from there, so it's dull and it's poorly localized. Referred pain is usually associated with visceral, and it occurs as a site distant to the area of pain, following the nerve tracts that go there. So referred pain oftentimes tells you what's going on. Right shoulder pain is often considered gallbladder pain. Left arm pain is oftentimes considered heart pain. So different organs radiate to specific areas. There are different causes for the abdominal pain. It could be mechanical. Somebody got hit in the stomach. It could be from inflammation or ischemia. GI bleeding, the next slide talks about the pathophysiology of that. But GI bleeding, you can determine where it's coming from based on the color of it. Hematemesis, the hemata part means that it's blood, and emesis means it's vomit. So hematemesis is when you vomit up blood. Hematochezia means it's bright red or burgundy, but this is from the rectum, so it's coming fairly close to the rectal area. Melena means that it is bleeding higher up because it's had a chance to oxidize the blood there, and it has become black and tarry, or really thick and sticky. Steatorrhea is when you have fatty stool, and that can cause a problem. This is the diagram for pathophysiology of GI bleeding. It's also in your textbook on page 987. I'm sorry, 897. Dysphagia is difficulty swallowing. It can be due to a mechanical obstruction or like too tight tie for anybody who still wears a tie. It could also be from a nervous problem, say somebody who's had a stroke, or from a muscular disorder such as myasthenia gravis is a possibility. If somebody is having trouble swallowing, you need to give them solids or thickened liquids first, and then follow it with the liquids last, particularly if there's a tumor. Heartburn is a burning sensation, and this is due to the reflux of acidic chyme, and chyme is, the food that we eat, and we've broken up and I've started down the GI tract. Flatulence is flatus. It means you've got gas. It usually has an odor associated with it. Frequency of stools is really important to know about. It could be diarrhea. How often is that diarrhea occurring? How much fluid is in there? What volume is there? Because you need to know, first off, what's the normal amount of stool. Somebody can have normally a stool 2 to 3 times a day or only once a week, and you need to find that out from your patient to know what's going on and whether or not you need to be concerned about that. There are different mechanisms associated with diarrhea. If you have osmotic diarrhea, this is usually due to lactose intolerance or a pancreatic enzyme deficiency, such as you have a child with cystic fibrosis. If it's secretory, it can be due to a tumor, hyperthyroidism, because that causes diarrhea, the presence of toxins, maybe some food poisoning type thing. It could be Crohn's disease, or an impaction will cause a secretory type of diarrhea. Motility diarrhea is due to, most often, a surgical procedure that's been done, like a gastric resection or a gastric bypass. It shortens the transit time. It could also be from fistula formation. Constipation is decreased or difficult defecation. Pardon me. That's why it's so important to know what's the norm for your patient. Changes that can contribute to constipation, you can have lifestyle changes where you decrease the amount of fluids, change their activity. Think about your patient when they come into the hospital. Do they eat what they normally do at home? The answer is usually no. Do they drink the amount of fluids they could at home? Well, if they're sick and having abdominal pain, probably not. So their activity has changed, their diet has changed, the fluid level has changed. Constipation is almost a given. Hirschsprung's disease is another possibility, and Hirschsprung's means congenital megacolon. So this is something that affects children. And they get a huge colon. And oftentimes these children will have to have colostomies in order to have normal bowel movements. Sedatives oftentimes have constipation as a side effect because they slow everything down. Narcotics, same thing. Hypothyroidism causes constipation because it slows everything down. Just as hyperthyroidism causes diarrhea, hypothyroidism causes constipation. Anticholinergics decrease motility because they decrease the acetylcholine and slow the parasympathetic nervous system. Abdominal pain. If it hurts to have a bowel movement, you're not going to try and have a bowel movement. And keep in mind, somebody who has a fecal impaction and stool impaction may still have some slight diarrhea leaking around it. So if your patient is having small amounts of diarrhea type stool, they should probably be checked for constipation. GERD is gastroesophageal reflux disease, and this occurs because gastric acid flows back into the esophagus, causing esophagitis because of the inflammatory reaction. It's usually due to relaxation of that lower esophageal sphincter. And then the food that's already been mixed with gastric acid will flow back into the esophagus. Hiatal hernia is a diaphragmatic hernia. It means that you've got a hole in your diaphragm. And so your esophagus, the connection just before the stomach, will kind of like kink back up through that diaphragm, particularly if you lay down or have increased intra-abdominal pressure, not intracranial pressure, intra-abdominal pressure. And that occurs if you cough, if you bend at the waist, if you have ascites, tight clothing, pregnancy, and you all know what ascites is, right? since I can't hear your answer, I'm going to tell you. Ascites is a collection of fluid in the abdomen. Oftentimes is a complication to severe heart failure or cirrhosis, which we will be talking about. Pyloric obstruction could be due to cancer or peptic ulcer disease. It's the narrowing or blocking of the opening between the stomach and the duodenum. Symptoms are vomiting, dehydration, malnutrition, and increased frequency of stools. Intestinal obstruction is when you have a blockage, and you're going to get colicky pain because the peristalsis is continuing. It's just not able to proceed past the blockage. And so then you will have vomiting. There's a table on page 900 that talks about the causes, and 901 that talks about the different classes. And there's also a figure there for the different types. Intestinal obstruction is something that does occur, particularly following surgery. So it's something that you need to know. Gastritis is an inflammation of the gastric mucosa. If it's acute, it will cause injury to the protective mucosal layer. It could be due to drugs, chemicals, particularly acidic chemicals, or the bacteria Helicobacter pylori, and that does live in the stomach and it can survive in the stomach. The only real reason we have gastric acid is to destroy bacteria that we ingest with our food. Oh yeah, it does a little bit with nutrition, with breaking down of the initial foods, but not a whole lot. Its main purpose is to decrease that bacteria. And so it kills all the other bacteria, but H. pylori can survive in a gastric acid, in a low acidic pH of 2. Or a little less, which is what the stomach's pH is, 2 to 2.5. And it can also move in among the mucous lining and destroy that mucus layer. NSAIDs will also cause gastritis. If somebody has chronic gastritis, that's usually the elderly. And they've done things over the years to affect that mucosal layer, like drink lots of tea. And this is showing a picture with the inflammatory area pointed out. You can see it right there, nice and red. In children, they may have GE reflux, gastroesophageal reflux, due to relaxation of or absence of the lower esophageal sphincter. It tends to be normal in newborns. They grow out of it. Younger children will have bleeding, vomiting excessively, aspiration, pneumonia is a possibility because they don't necessarily know to turn their head if they start to throw up, or to sit up if they're going to be nauseous. So it can cause aspiration pneumonia, esophagitis, which is inflammation of the esophagus, and a possible stricture formation as a result. Dysphagia, difficulty swallowing, and the child will have failure to thrive because they are not absorbing the nutrients they need. Oftentimes it's due to a decreased hormone response or decreased maturation of the lower esophageal sphincter, so it doesn't grow the way it's supposed to. This next picture shows you a picture of gastroesophageal reflux and what the esophageal stricture looks like as a result. And this flow sheet is showing you about intestinal obstruction and what it causes for the patient. Possible causes could be atelectasis and pneumonia, a loss of water and electrolytes, so they're going to become dehydrated, have hypokalemia, which could be life-threatening, hypovolemia, shock, peritonitis. This is also on page 902 in your textbook. I think you should know it. And this is from the memory book. It's just showing you different ways to try and remember symptoms of bowel obstruction. Oftentimes, the bowel sounds initially will be very high-pitched, and then they'll be silent. In other words, you won't hear anything. And before you can say that there are no bowel sounds, remember you have to listen 5 minutes in each area to make sure that that's true. Peptic ulcer disease is a break or ulceration in the lower esophagus, stomach, or duodenum. The risk factors for it are smoking, Helicobacter pylori, H. pylori, advanced age, alcohol or NSAID use, excessive. Chronic disease can also cause it. There are different types. Your duodenal ulcer is usually due to H. pylori and NSAIDs, nonsteroidal anti-inflammatory drugs like aspirin. That's the most frequent form, and it does occur more so in younger adults. Gastric ulcers are usually occur between the ages of 55 and 65. H. pylori and NSAIDs, again, are the major cause. There's a table on page 906 that compares the characteristics of gastric and duodenal ulcers. You should look at that. A stress ulcer is also called a curling ulcer, and this is due to too much cortisol release, and this usually occurs because the patient's under a lot of stress, maybe a major accident or a major illness, trauma or damage to those nerves. Those will cause a curling ulcer. A curling ulcer is also called an ischemic ulcer. Now, a Cushing's ulcer is due to head trauma, and that head trauma causes overstimulation of your vagus nerve, so that causes increased gastric acid production and decreased flow to the stomach. So those are the different types of stress type ulcers. Curlings is directly related to a stressor causing an increased release in cortisol that's causing an increase in gastric acid production, and by stimulating your epinephrine and norepinephrine, a decrease in the blood supply to the stomach. Cushing's ulcer, again, decreases the blood flow to the stomach because the vagus nerve slows things down and increases your gastric acid. There are some figures you might want to look at on page 904 and 905 about peptic ulcer disease. Here's a picture showing the different lesions of a peptic ulcer. You've got the erosion where you have somebody has a little bit of burning, not any real pain. The true ulcer means it's going through several layers. It's much more painful, more constant, and it can go practically down all the way to the serosa. All of these tend to get better after you eat because that gives you a cushion there. This again is someone showing peptic ulcer disease, the different types. You've got gastric and duodenal, and your stress ulcers. Give you something to, this is from the memory book, so it might help you remember things. And this is the flow sheet for gastric ulcer formation. It's in your textbook on page 906. Post-gastrectomy syndromes occur following surgery, gastric surgery. These are usually found most often in the hospital. And dumping syndrome is probably the most common. You'll have rapid emptying of hypertonic chyme. In other words, the electrolytes have not been taken out of the food as it passes because it has, the transit time is so great. You have a bowel movement 10 to 20 minutes after eating. Usually it takes at least 10 hours to 24 hours before somebody has a bowel movement. You can tell this, by the way, it will not be tested on, but it's just FYI. If you eat corn, corn tends to exit your body looking very similar to what you eat it for. Eat like it unless you puree it. And so I want you to eat some whole kernel corn. Time when you eat it. Then actually look at your bowel movements for the next couple days and see when you see it for the first time in your stool. That will give you the transit time that's normal for you when you have a bowel movement. So if you had it for lunch yesterday and you don't notice it in your stool until tomorrow, it's going to take you almost 48 hours to clear that stool. So you need to know about that. Symptoms, you'll have nausea, vomiting, you'll have osmotic diarrhea because it's going to have electrolytes in it, pull lots of fluid with it. You'll have weakness, pallor, hypotension, which is a low blood pressure, and cramping abdominal pain. Dumping syndrome does respond to dietary management. You're going to give them more like 6 to 8 small feedings rather than 3 big meals, and you're going to do things with their fluids. You'll learn about that in Nursing 123. Other syndromes are on page 907, and you need to look at those. But here again, we have a picture of a dumping syndrome. It works really, really fast. And as you see, they've got no fluids with your meals, no high carbs like breads and potatoes. So those are things to look at. Ulcerative colitis, risk factors, age 20 to 40. Being white, having a Jewish descent, family history of it. Ulcerative colitis is a chronic inflammatory disease causing ulceration of the colonic mucosa of the rectum and the sigmoid colon. It will also cause edema and thickening of the mucosa that may narrow the lumen of the colon. Cause is unknown. Does have a family tendency. It is associated with autoimmune disorders. So if you have, say, rheumatoid arthritis, which is an autoimmune disorder, you may have ulcerative colitis. They tend to go together, all different types of autoimmune disorders. Patho for this is inflammation in the large intestine causing ulcers, abscesses, and necrosis. Your symptoms are bleeding, cramping pain, diarrhea, and just generalized abdominal pain. They may have as many as 10 to 20 bloody stools a day. They may have continuous abdominal pain. Because of all those stools, they may become dehydrated, develop anemia, weight loss, fever, bleeding, and inflammation. They will have intermittent exacerbations and remissions. In other words, they'll have periods of time when they don't have the diarrhea, and then they'll have times when it's really, really severe, like they can't leave the bathroom. There's a table on page 909 that looks at ulcerative colitis, and here are some pictures where you can see the ulcerative colitis on the left, and that repeated cycle of ulceration alternating with the deposition of granulation tissue during the healing phase results in the development of raised areas of inflamed tissue that resemble polyps. And this is a polyp right here. And your ulceration is over in here. Crohn's disease, or granulomatous colitis, or regional enteritis, basically all the same thing. Why we have to have multiple names for the same thing, I'm not really sure of, but they are. This is very similar to ulcerative colitis, except it occurs in a different area. You'll have inflammation of the large and small intestine, and it will involve mainly the ascending and transverse colon, but it will produce what are called skip lesions. So a skip lesion means you're going to have normal healthy tissue, diseased tissue, normal healthy tissue, diseased tissue throughout that area. You'll have exacerbations and remissions with this also. Stress is a major factor in its exacerbations. Symptoms, you'll have irritable bowel. With ulcerative colitis, you have bloody diarrhea. With Crohn's disease, you have non-bloody diarrhea. You will have weight loss. You will have lower abdominal pain. Because it causes diarrhea, you're going to have possibly malabsorption of your vitamin B12, and that could cause pernicious anemia, which is a major concern. It can form fistulas in fissures and strictures, so it can cause abnormal connections with other tissue and organs in the abdomen. And if you smoke, you're going to make this disease a lot worse. So this shows you where Crohn's disease occurs. It's down lower. You can see the inflammation. They've taken this section and blown it up down here, and you can see the inflammation in there. And here we have this one showing the ulcer down here. And then polyp formation and inflammation within the ileum. This one's also in the ileum, and it's showing some granuloma formation here. And the one on the, I'm sorry, this is the one that's showing on the far right. This is showing the scar formation that occurs because of the Crohn's, shows the ulcer down in here. It's ugly. This is from the memory book. It's just showing you the different pictures, ways in which to try and remember the difference between Crohn's disease and ulcerative colitis. And this is where I'm going to stop part 1, and we will continue with part 2 whenever you click on it to open.